Ladies and gentlemen, boys and girls, welcome to another installation of Health from the Inside Out. You know what? To explain a little bit about where the concept of health from the inside out is, if you stop and look, every time you go to a mirror, you see what's happening on the outside of you. You make sure every hair is in place. You make sure that the makeup for the women is totally together. Guys, you make sure that the chest is looking good. You're sticking it out far enough. That's what we do. That's our ritual every day. But little do we know that the inside of us is going through its own metamorphosis, its own changing. We may not be able to see it as much because that is something on the inside. So this is what we're trying to do. I'm bringing you the best that I can as far as medical advice from some of the top doctors and surgeons in the country that's going to show you how to maintain your health, to get back your health, to reclaim your health so that you can be healthy from the inside out. Hey, welcome to the show. Good morning, good afternoon, good evening, whatever time zone you're watching it from. I'm hoping you're sitting back and you're chilling because you're in for a great treat. My name is Dee Nice, and I'm the show producer, the creator, and now today I'm going to be the host because I have a fantastic Mondays. All those kind of phrases you want to say, boy, this is off the charts. One of the hottest podiatrists in the business today. My friend is going to come on and tell you what his suggestions are on how to maintain that foot healthy appearance. You know, I was reminded of the movie Boomerang. And it was funny because when Eddie Murphy was sitting back looking at this young lady's foot, he had a comment to make this boys the next day because he said the feet was scary. And, I know guys, we like to look at women's feet. We like to look at women from the head up. We need for them to have their nails meticulous, toenails together. And if we find something that's wrong with the feet, it just kind of does something. And that's a bad calling card to start with. So sometimes we don't know what's going on with that person. But tonight we're going to bring in an expert that can tell you how to beat some of these issues you're going through and how to sustain your foot appearance and your footwear. And once again, like I said, welcome. My name is Dee Nice, and I want to take a quiet second here to just kind of reflect on when I say health from the inside out, it's not only about just what we can see and what we can feel, but one thing that we were brought to bear to mind that's been a problem in our society for a long time is we are overlooking the abuse that is better known as mental health. Mental health is a very tricky, slippery slope. And there's a lot of people that are sliding down that slope every day and have no way of getting out. So in the future, I will plan to bring on some health advisors and some psychiatrists and some psychologists and people that are able to work with people's psyche because you've been locked up for the last 15 months to 12 to 2 years, depending on what your job has been and what you're doing. But being able to be released now, and guess what? Now we're finding out that there's a newer variant that is attacking it again, that's worse than the original. So now it looks like, we're up in the air again, whether we wear a mask, whether we don't wear a mask, if we're vaccinated, what do we got to do if we're not vaccinated? So it's like a game of chess, but you know what? Your life should be more important to you than playing Russian roulette. If you're not vaccinated, I'm going to tell you, and hey, look, this is my opinion, and you could take it as much as you want to, as deep as you want to. But look, I'm saying if you're not vaccinated, then do something for others around you because you don't know who you run into every day whose compromised immune system may just take them out, put them in a hospital, or may kill them, whether it's your family or friends, coworkers. So if you don't want to do it for yourself, do it for others. And if you can't, then you know what? I can't help you because when you're laying up with them tubes in your nose and you're trying to gasp for your breath and wondering how you got there, then you know how you got there. You refused the life raft when you fell off of the ship. So please don't feel you're too cool or you're too busy or whatever your excuse may be to get vaccinated. Now, that's my 5 cents on the vaccination. But going back to the mental health aspect of it, we had the Olympics that has been going on for the week, and it's just about to wrap up. But we had one part of the Olympics, which is what we're talking about today, and that is the gymnastic aspect of the Olympics. And one of the greatest, the GOAT, so far at 24, Simone Biles. And she had a chance to take a delegation of gymnasts over to Tokyo 2020. And in one of the routines, starting out, I think it was a vault, then she could feel that she was off, and you could see it in the vault. You could see the landing, everything. She didn't stick it. And at that time, she decided, look, I've got to take a back seat here, and I've got to work on some things that are bugging me. You know what I'm saying? So she was later interviewed and talked to some people and let them know that she's got to work, and she just put it as her mental health. And so we don't know. Nobody's walking in her shoes, so you don't know what that means and how deep it goes. But to have jumped out like she did in the Olympics the first time and have made such significant strides all the time and being on point all the time and just being ready to just perform at such a high level of intensity. Let me tell you something, whether you're a football player, whether you're a soccer player, whether you're a tennis player, these things, these pressures get to you. Whether it's in your gut, whether it's anticipation, the nervousness tears your stomach up, no matter what is the mindset, these are things that are internalized, but we don't see it on the outside. But some people out there are quick to blame her and say, you know what, it is all about one thing. This is your job to represent America as a gymnast, and there have been people in the past before you that have gone and almost broke their neck and continued on and fought through the pain and whatever. But come on, you know what? You're not walking in these people's shoes. You don't understand that dire effect that it has on them internally, emotionally, physically, personally. You know what I'm saying? And she's been through some problems. We found out not too long ago that there was one of these doctors for the team that was molesting these girls. So, that's another dramatic experience that these young ladies are rolling with too at a young age, thinking that this was part of whatever this doctor's examination was, but it was a hoax. It's full of trash. And so they're dealing with these scars. Once they figure out that's what went down, then that does something to your mind. And then you got to come out day after day, month after month, year after year, on center stage, on the main stage, and perform at your top peak. Let me tell you something. There have been stronger men that were football players that could take 400 pounds hitting them during a whole 60-minute game that have punked out, if you want to do it like that, have left the game, retired early because they couldn't deal with it anymore. Psychologically, mentally, physically, it was it for them, and they retired early. And that's just to name a few. So imagine if you got young ladies, okay, that are going through this one here and going through the different problems they're going to add to this, and then you want to blame them and say, let's look at your professional. As professional, once you get that Olympic gold, and you've got the world championships, and you've got the accolades and accomplishments that Simone has, believe me, she has already gotten her title as GOAT. So no matter what she went through this time, she felt like it was time for her to step back. And the good thing about her stepping back is she allowed her teammates to stand on their own, which basically they might not have had to do that. Everybody depends on the GOAT. But when she was no longer able to lead the Franks, then guess what happened? They stepped up and they did what they needed to do. And also the young lady that was doing the individuals in her place, kudos out to her, because she had to claw from behind. Those Russians were bringing on some heat, and she clawed from behind, and she now is in as prestigious class as being that individual gold medalist. And so had they not won it that way, then there would have been more, believe me, there would have been more complex tweets out there saying, well, she caused them to lose this. And, people, stop judging. In fact, if you want to judge, I'll tell you what you do. Go to your mirror, point to yourself, and start talking about some of the flaws and trips you've done, some of the funky stuff that you did, okay? Even as far as back as an hour. and you go back and see how that feels trying to suppress that and hold that in. So before you throw rocks at somebody else or point fingers, guess what you see? When you're pointing one towards you, there are the rest of them pointing back to you. So do yourself a favor and fix yourself and stop trying to, you know what I'm saying, hurt somebody else or stigmatize somebody else. Because let me tell you something, a mind is a terrible thing to waste. My hat's off to the Olympic team this year, the girls Olympic team this year, for what you're doing, for Simone, for taking control of what you're doing, and even for the other tennis player, Osaka, or whatever her name was, I hope I'm pronouncing it right, that had to step back from one of the events because her mental. When people tell you they got mental issues right now, then I'm telling you, you don't know where that's coming from. Go to Venice Beach. Go downtown LA, where people are pushing, these homeless guys are pushing people in front of buses, hitting them upside the head with stuff, doing all kind of crazy stuff in the sake of mental issues. So we don't know what's going on in people's heads. So stop judging. Okay? Now I'm going to get off my soapbox because I have a great show for you tonight. I have the one, the only podiatrist to the stars. I'm talking about my friend and soon to be yours, Dr. Weiss. Now, this young man, not only I got a chance to see him up close and personal as he worked on a couple of major problems that I had, you know what I'm saying? And, when you get older, you got some of your blood flow issues or whatever. When that happens, and that can sometimes get into, your way of living. I've had some hip issues. That can also throw off the way you walk and whatever. And so I had to find somebody to bring me back into alignment. So that's when I found this young man with the Cedar Group. And let me tell you something. Since I saw him, this man has been remarkable. He's got his own swag. He's got his own way of doing things. And people respect him. You should see him as he works in his office. They respect him, snap, crackle, and pop, but he don't have to holler, he don't have to scream, he doesn't have to do anything but be himself, and people follow him because he's the cat that has the answers. And today we're going to ask you some complex issues on how to keep your footsies in good stead. Ladies and gentlemen, help me welcome to the stage the one, the only Dr. Weiss. Hey, boss, how you doing?
Hey, how are you?
Man, it's good to see you. Good to see you, man. I know we had part one, but walked away from that one just like going to a theater and having that popcorn box of popcorn. You reach in there and there's only a couple kernels. Where's the rest of the popcorn? So now I'm back to get the full box, man. You know what I'm saying? So,
Great.
Doc, we've
Yeah.
been isolated. We've been couch potatoes. We've been to where all we could do is if we had to walk the dog, walk around the block or something like that. And that's been the extent of what we've done for the last year and a half. And now suddenly they're telling us, okay, the floodgates are open, do what you do. And friends of mine are going up to the pathways and hiking, and others are jogging, going to the beaches and whatever, and running through rough terrain and whatever else. And that is all a part of what your foot goes through to carry different sizes, different weights, different gaits, and everything else. So I never realized how important until I met you and did my research, how important the feet are to the body, man. Come on, this is ridiculous how many people really are doing things that they don't realize that's going to cause them pain and suffering later down in their life. So I want to take a brief minute, Doc, and ask, okay, when I'm doing my first, just getting off the couch for the first time, okay, then what kind of limitations should I put on myself as far as walking, jogging, or whatever? Should there be some kind of limitations that I do? What's my introduction back to movement 101 after the pandemic?
Sure. Yeah, absolutely. I mean, the last year and a half has been a challenging year for everyone. I know we all had goals. We all wanted to do more, but it's been hard. It's been challenging. These are uncharted times. So now that things are, somewhat better, although still far to go, with this new variant and whatnot. We're really encouraging people to get out, to go back outside and exercise and be with friends, at a distance and get back out there and start increasing the activity, walking, exercising, etc. You have to set goals. You have to be realistic. If you really haven't been too active and you've been more sedentary over the last year and a half, you have to understand that it's going to be a slow transition until you get to that point where you want to be. If you're used to jogging 2 miles and you haven't jogged in the last year and a half, you're not going to be able to go out and do 2 miles. Start with half a mile or a quarter of a mile, or go on a long walk. Likewise, if your goal is to hike, start with a short hike, walk on the beach, but do it carefully, because the goal is to kind of ramp it back up slowly and safely, so you don't develop an overuse problem, something that's going to set you back and then keep you back out of exercising.
Now, Doc, I got a question, because I put this out on my social media, just bounced it out there, questions that may be asked from somebody to a podiatrist, to their, you know what I'm saying, foot doctor. And what I came out with was some way out questions. So if I can impede upon you for a second, I see you have that foot model there. If you can kind of like give us a demonstration on what that looks like when a foot is in motion.
Sure. Yeah. Basically, in terms of the foot, there's a lot of common problems that I see in my office on a daily basis. There's people that have forefoot pain. There's people that have heel pain. There's people that have arch pain, people with flat feet, people with high arches, people with tendonitis, all kinds of problems. So generally, when I see a person in the office, I oftentimes look at their foot type, because that gives me a lot of clues in terms of what type of problems I'm looking at. For example, over the last year and a half, people have been inside their house working remotely. A lot of people have been walking bare feet, using slippers. A lot of people have developed certain problems that are kind of classic to that environment. Forefoot pain. Okay, if you're not wearing supportive shoes, you're loading the forefoot under these metatarsals. As the foot loads, you're developing forefoot pain. We call that metatarsalgia. Another name is capsulitis. It's essentially inflammation or pain in the ball of the foot. How do you treat it? You get the pressure off the ball of the foot. Okay, you stop walking barefoot. You start using supportive shoes or sandals in the house. Another common problem is something called plantar fasciitis. This ligament right here is called the plantar fascia. It starts in the heel right here and it spans forward towards the ball of the foot. If you don't have proper support, that plantar fascia ligament is going to get stretched and pulled. And when that happens, you get inflammation, micro trauma, micro tears along that fascia. The plantar fascia pulls at the bone. A lot of times the bone reacts by forming a bone shelf or a bone spur, and that can create pain, deep inflammation, etc. And that's a common problem that I see in my office, something called plantar fasciitis. How do you treat that? Stretching exercises, supporting the arch, using good shoes, using arch supports. A lot of times we'll do cortisone injections if it's been going on for a long time, especially if people have already started some of those other treatments, physical therapy, and so forth and so on. Achilles tendonitis, similar to plantar fasciitis, where there's strain in the back of the calf going down to the back of the heel. Most of the time people have inflammation or tenderness about 2 inches above the heel bone in the back here. How does that happen? It's an overuse injury. Maybe you were playing sports. Maybe you were walking without good support. Maybe you started walking hills. Uphill puts more stress on the Achilles tendon. Once you strain that Achilles tendon, you get inflammation and pain. Sometimes people even get little partial tears. Obviously, a lot of athletes get complete tears of the Achilles tendon. That's usually a little bit more obvious. But how do you treat that? Well, you decrease your activity. You use some kind of a heel lift. If you're a lady or a woman, you can wear a shoe with a heel, like a wedge or a high heel. You can put a heel in an existing tennis shoe or sneaker. Do some gentle stretches, massage, anti-inflammatories, ice, things like that. Other common problems are stress fractures, especially if you're thinking about increasing your activity. Most people don't recall an injury. They start increasing their activity. They get stressed in these bones. These metatarsal bones right here are thin, long bones. A lot of times they're susceptible to developing stress fractures. Most of the time, like I said, people don't recall an injury or an accident, and all of a sudden just develop pain and inflammation. It's hard to diagnose because it doesn't show up on x-ray right away. Usually takes about 2 weeks to show up radiographically. So a lot of times, even if they go to urgent care or the emergency room and have an x-ray, it doesn't show. You really need to treat it like a fracture, a stress fracture, and then do a repeat x-ray 2 or 3 weeks later to show that injury. A lot of people with flat feet, if they're getting overuse or not wearing the proper support, they get something called posterior tibial tendonitis. It's essentially like a symptomatic flat foot. It's this tendon on the inside of the foot and ankle gets strained. How do you treat that? You usually decrease activity, use some kind of an ankle brace. We like to get those patients into good custom orthotics, something that's going to hold their arch up and suspend that medial arch, and then talk to them about shoes. There's shoes that are specifically designed for people that pronate. They're called anti-pronation shoes. And also talk about some therapy and other things like that. So a whole lot of different things with foot and ankle. Those are some of the more common problems that I see. I know that a lot of people have those issues, and some of them have gone medical attention. A lot of them haven't. But those are probably some of the more common things that I see in my office.
Now, I got an email from a guy named Philip. Hey, Philip, from D.C., and he said that his father was in the Marine Corps and was a captain in the Marine Corps and retired, and so he wanted to follow in his father's footsteps, only to find out that when he went down there to enlist, he passed all the tests he had to do mentally, and then when he went to take his physical exams, he said that they came back and said that something, like you said, well, I forgot the term for it, he doesn't even know it, but he said that they told him that he had flat feet and that they couldn't take him into the military because of flat feet. Now, they said that's what they say, that they can't take him. But now you're saying there's something that could be done, because I would really like to get his brother a ray of sunlight. Once they determine that you have flat feet, I'm sure that there is a method to their madness, because if you got caught out being out in the field or doing your bivouacs and whatever else, like I was in the Marines, so I know how that training is. You've got to have, so much strength in, your feet and ankles and whatever, to be able to go up these terrains and walk these miles or whatever. So with the limitations, there's enough limitations with this flat feet, you said, but is there any hope down the horizon that he can somehow have an arch, or is that something that's just asking too much?
Right. That's a good question. So I see a lot of people with flat feet, and sometimes people with flat feet are asymptomatic, meaning they don't have any problems. And that's okay. So you can have a pancake for a foot, and if it's asymptomatic, great. Other times people, with flat feet are oftentimes more susceptible to having problems. One of the problems they found in the military when they were enlisting these cadets where people with flat feet ended up getting these overuse problems or symptomatic flat feet. They would start their training, a lot of times running, excessive walking. And then more often than not, these people were complaining of arch pain, medial foot and ankle pain. And what they found over time is, hey, if someone has flat feet and they're more susceptible to these injuries, they're really not going to serve us as well as someone that doesn't have a flat foot. So they basically drew the line at that point and said, listen, we're going to start kind of going through these applicants and dissuading these people with the flat feet from enlisting, because we know that down the road, they're more likely to develop these secondary problems. And that's kind of how that came to be. In terms of treating them, it can be a challenging thing. And, initially when I see a person complaining of flat foot, they typically complain of arch and foot pain on the inside of their foot and ankle, kind of along where my finger is. Now, you don't see the soft tissue because this is obviously just a skeletal model, but there's a tendon here called the posterior tibial tendon, and it attaches right here. And what happens is the foot flattens out, it really strains and tethers that posterior tibial tendon. And that's what people feel with a flat foot, is that tendon starts wearing down, and you start getting degenerative changes of that tendon and micro tearing and trauma. And then it becomes a symptomatic flat foot. And how do you correct that? Well, it's tough because you've got to basically correct their foot type. And how do you correct their foot type? Well, you've got to support that arch with an aggressive custom arch support most of the time. Sometimes some kind of a brace. There's even custom braces. And if that doesn't work, then we work it up a little bit further, get MRIs, look at the damage of the tendon, how extensive that tendon injury is, and then sometimes do surgery, which essentially consists of a flat foot reconstructive surgery. And it's a big deal, and it's definitely something you want to try to avoid if you can. But for someone whose life is compromised or their quality of life is impacted because of a symptomatic flat foot, then that's certainly an option that people will make at that time.
I want to just flip reels for a second, doctor, and go into like a kid situation, because my grandson, I remember something. We weren't adapted thinking about podiatrists at the time, but my grandson, I went over to the house one day, and his nephews they were older than him. They had figured that they can get a big laugh out of this boy. Had to be at least about maybe 8 months, because he's always been good developed. But he's 8 months old, and they were standing him about 6 feet from the couch, and they'd be sitting on the couch and they'd stand him there and let him stand on the piano, so he's standing, and then they'd call him over to them, so he's walking at that 6 foot, but he just figured out that he didn't want to fall. There's something about him growing up, he never wanted to fall. When he falls, he learned how to arch his back, not to hit his face. Something about that kid was wired different. And so he was running from the piano 6 foot over to the couch, and they would let him do this again and again. Well, I saw him, I'm like, how long have you guys been doing it? So it's been a while, and I started noticing, Doc, that he started developing bow legs, and so that freaked me totally out. So I jammed my daughter about it, and I was trying to figure out what's going on. But over the years, for the next couple of years, for whatever reason, I think it's a lot of prayer, that he finally got his legs straight. So, I mean, I know part 2 of the show, we're going to be talking about some of the surgical things and how to deal with it and what to know about when you're surgeon, how to be able to identify it. So, ladies and gentlemen, I hope you're enjoying Health from the Inside Out. Once again, I'm Dee Nice, and I've got one of the hottest podiatrists on the planet with Dr. Weiss, and know for certain that if you got a problem, we're going to try to solve it so that your feet becomes one of your best friends. So until we meet back in a second for part 2, this is Dee Nice saying, watch your health, especially from the inside out. Welcome back. This is Dee Nice, and you're watching Health from the Inside Out. And like I promised you, I've got the greatest rockin'est podiatrist on the planet, Dr. Weiss, and he's here with us tonight to try to explain. The first part of it was kind of like analyzing the foot and some of the different ways that you can protect it and some of the ways that it goes into misalignment, mishaps, to where it's going to bring us to the second part, which is being able to figure out what's going on and look forward to possible surgery to correct it. So this is the second half of the show, Health from the Inside Out. And we are today with the illustrious Dr. Weiss. Hey, boss, how you doing?
Good, thanks.
Now, just like I said, was that a freak accident, man? I mean, first off, Doc, I've never seen nothing like this before. I saw it one time and it pissed me totally off. You know what I'm saying? To see him doing that to the little baby, because I mean, you know, he seems like that's the stage when they're starting to crawl, and I'm seeing him have to run for his life, and they would get the kick out of it. So I don't know how long they had been playing that little game before I got there, but yeah, he started looking like he was going to have the bow legs, and it just came out of that. Now, is that something that is just a blessing, or does that happen? Have you seen that happen?
Yeah, so kids are very resilient, and that's very common for kids. They go through different stages of development, you know, from being bow-legged to being knock-kneed, sometimes, you know, out-toeing, in-toeing, and more often than not, those kinds of things work themselves out. Obviously, there's, you know, those situations where they don't, and they have, you know, torsion, you know, basically from the femur can be, you know, rotated in, or the lower leg, the tibia can be, you know, rotated or twisted. But for the most part, that's common normal development for pediatric and young kids.
Now, that's a blessing because, like I said, man, I couldn't. And now he's since he's been 8, he's been looked at by scouts. Man, he's at the Boys and Girls Club in Venice, where I mean, you have celebrities all around just putting money in it and really appreciating that one there. And he's a standout ball player, man. He just 3-point shots, I think, is about like 60-some% on the same size net that they're using in the NBA. Now I don't see Shaq ain't even shooting that percentage. So, and then he's got to run at him because I got to really slow him down. He's got basketball etiquette inside. I asked him one day, I said, what do you want to do when you graduate? He said, I want to be a ball player. I'm like, oh, no, we're not going there. That's the first thing me and come. That's what a lot of our neighborhood kids have been taught to feel like that's our ticket out of the go neighborhood, out of the ghetto, is to be basketball, football, whatever. So I wasn't going for it. I said, look, you need to be academically inclined so that whatever, if your dream doesn't pan out, guess what? Which it'll probably not. The percentages are high that they won't. You've got to be able to do something else. But he told me he was stuck on it. It wasn't until about a month later, my daughter said they're going to this, like the little finals championship. And I went there and watched the boy play. And I didn't even recognize my own grandson, because where these little kids basically be kind of like half walking down the court or whatever, this boy would sprint down there like they called him a young Magic Johnson. He'd be doing wraparound passes and stuff like that and hitting the kids all in the chest. And these kids are looking like they pissed off at him. They wondering what they did to him. But I'm like, I had to slow him down and say, Mir, these kids are not on your level. They don't understand what a ball coming at them like that means. I mean, you know, but he's like, well, Popo, I'm trying to keep the team going. And I'd watch him many times. Say, I'm going to put the team on my back. And that boy would go out there and shoot 30, 40 points. And I'm sitting there going, who the heck is this youngster? And so he plays great. He's destined to be in that category. He's tall for his age, way tall. He's about like, now just turned 12, and he's going on about 6 now. And so he's doing the thing, and he's staying in school and doing what I tell him to, because otherwise I would let him play. But looking at some of the lesser athletes and parents that are pushing these kids along that athletic track, now, is there something that they're missing or something that they could be doing, destroying these kids by trying to force them into, you know, sports at a young age?
Yeah, I mean, I think that sports and by the way, I'm sure your grandson has good genes, so that's kudos to you right there. But in terms of, you know, these young athletes, I think sports is great, and you know, I've got 2 boys and they play sports, and I certainly encourage that, and it certainly beats the alternative most of the time. So certainly something that you encourage, but can we push these kids too far? Absolutely, just like anything. Especially now, I see with like baseball, for example. When I was a kid, and I'm sure when you were a kid, baseball was a spring sport. Maybe it went into the summer, but now you've got fall baseball, you've got spring baseball, you've got summer baseball, and you've got some of these kids that are playing the same sport all year round. What does that do? Creates overuse injuries. Some of these pitchers that are pitching all year long, they're developing things that we never even thought about, you know, 15, 20, 30 years ago. Shoulder injuries, and people, you know, 12, 13 years old having surgery. So these these are real concerns that parents and coaches have to be aware of. I think the key with kids is everything in moderation, be realistic, let them have fun. If they take it to the next level, then great. Support them, encourage them, enrich their lives, and let them appreciate and love sports. But be careful and be mindful of their workouts and their training and things like that.
Got you. Now, here's another common thing that I've heard people complain about, and it's been called shin splints. And I take it that it deals with the shin,
Right.
but you know what I'm saying? Is that something that is from something that, if it's not taken care of, can alter the foot? Does it go to the foot, or does it come from the foot up or down, or how does that scenario commonly work?
Yeah. So shin splints is basically just kind of a term that we use. It's a tendonitis, another form of tendonitis, just like we talked about the Achilles tendonitis. The shin splints is tendonitis of another tendon where that originates from the front of the shin area, okay, or the tibia bone. It's called the tibialis anterior. It's an overuse injury, so a lot of runners get it. A lot of these high school athletes that do cross country, that are pounding their feet on the pavement day after day, they get these overuse injuries, shin splints, and it's a tough problem. And some of those overuse injuries or shin splints can even turn into stress fractures of the tibia. Because you have to listen to your body, you need to know when you're overtraining. You need to know when you need to cut back your training. Or alternate the type of training and do CrossFit or cross training. And that's the importance of having good coaching and having good self-awareness and knowing when you're overdoing it and knowing when to cut back. Usually for shin splints, we usually recommend cutting back on the activity or the sport, or switching. So like if a cross-country runner is getting shin splints, kind of taper them off the running, maybe keep them to shorter runs. Maybe switch them over to some cycling just to keep their cardiovascular exercise. A lot of times we'll get those people into good custom inserts as well, which helps. A lot of times we'll do athletic taping to mobilize or support that leg and tendon. But it can be a challenging problem, just like any tendonitis injury.
Now, when I see athletes, Doc, that have this kind of like, it's usually like this reddish kind of tape that they have, especially the gymnasts, that they have around their feet and ankles and stuff like that. Is that something like a stabilizer, or is that something that's needed, or to avoid the pain or to diminish the pain?
Yeah, so the kinesio tape has become really popular, I'd say, over the last 10 years. It's pricey, so not everyone has access to it, but a lot of athletic trainers do use it. It helps them mobilize different joints, different tendons. It allows for some motion, but restricts excessive motion, and that's what people really like about it. Before kinesio tape, we used a lot of athletic tape, which was very good, but it's more rigid, so it's more restrictive. Whereas the kinesio tape just gives you that motion and essentially prevents that over excessive motion.
Now, Doc, when I was playing ball later on in my life, I've had a couple of incidents where it was termed as rolling my ankle. And so I'm sure it's common out there, when you come down and you come on it wrong, stuff like that. And I think it's called different, because I've seen some of the NBA players where they hit it the same way. You could see it just kind of like roll. And,
Sure.
Then something like that. How intense does it have to get before you find out that there's some surgical scenario that has to follow that?
So a very common problem, not just with athletes, but with anyone. You're walking down the street, you hit a crack, your foot goes this way, your ankle goes this way. A couple of scenarios or things can happen when that happens. When the foot goes like that, it's called an inversion injury. When that happens, you can either break this bone right here, which is the fifth metatarsal. You could break this bone right here, which is the fibula. Okay. You can tear these ligaments right here, which are the outer ankle ligaments. Okay. And you can do other things to different tendons and things like that. So when a person has a bad inversion injury, It could be just a little sprain and no big deal. It gets better in, a week or two. But oftentimes when I see those patients in my office, it's, a matter of working it up, getting x-rays, examining, seeing what the injury is. I had a patient this week in my office that fractured her fifth metatarsal base, her ankle joint right here, or rather her ankle bone here, and then also tore those ligaments. So, that's a pretty bad injury. She needs to be immobilized. Fortunately, the fracture, everything's in alignment and in position where it's supposed to be. Sometimes we need to get MRIs to evaluate the soft tissues and the ligaments, because remember, x-rays just show bone. And if we really want to appreciate what the tendons and ligaments are doing, we've got to get that MRI image to appreciate that. Obviously, any type of fracture that's displaced, meaning out of alignment, requires surgery for the most part, okay? Because we want bones to be anatomic. That's the position they're intended to be. So if they get out of position, then we're going to have that conversation with the patient and show them the x-ray and say, listen, this bone needs to be right here. Usually surgery requires opening up that skin, reducing the fracture, and then fixating it with some form of a screw or plate or combination of screws and plates. Usually the recovery on something like that is typically about 2 months, give or take. A lot of times physical therapy afterwards to help with the rehab and ankle strengthening. And then for athletes, that can be a few months sometimes before they really get to that level of activity that they need to be.
Now, Doc, let me ask you, I know when my bones sometimes hurt, my knees or ankles or whatever, I can put like this heat rub or whatever, or heat bags or whatever. Now, I know there's supposed to be some kind of rule of thumb, and to clarify it with me and others watching, when do you apply the heat and when do you apply the ice?
Yeah. So ice obviously is good at reducing inflammation. It's good initially after an injury. So let's say you roll your ankle. You definitely want to ice for the first 2, 3, 4 days after the injury. That will help reduce the inflammation, any blood accumulation. You want to elevate. You want to stay off of it. In terms of ice after like an older injury, towards the end of the day, typically, remember, if you're icing something, you're kind of freezing that part of the body. It's going to create stiffness. You don't want to ice and then go for a run or a walk. You want to ice and go to bed kind of thing. So you're icing towards the end of the day, calming down the inflammation, and then basically kind of keep taking it easy after that. Heat's good at loosening things up. So if you're soaking your foot in like a warm whirlpool or Epsom salt soaks, that's good at loosening things up. That's good at kind of like the tail end of an injury where you're trying to regain your range of motion. It's also good at just kind of soothing things and calming things down, for things that are hypersensitive, things that are stiff, after being in a cast for a while. So that's what heat is. Any of those topical treatments, it's kind of thing. It's topical. If it helps, great. I haven't had too much success with a lot of topical creams. I mean, there's the heat creams, like the icy hot, and then you've got like the pain, the aspergels, and the lidocaine gels, and that's more of like a numbing. Then you have the CBD creams and things like that. So it's just one of those things. I tell my patients, if it helps, great. Go ahead and use it, but a lot of times it's just not enough to kind of penetrate and get to the source of pain.
Now, there's some surgical questions I have, but before I get too far off base, I want to find out the pros and cons and when to use it and when not of an injury that takes a cortisone shot.
Mm-hmm. Yeah, so injuries, cortisone's a tool that we use often in our practice. The typical patient that's a candidate for a cortisone injection is not a patient that comes in with an acute or fresh injury. So if you've sprained your ankle 3-4 days ago and you come in, you say, Doc, give me that cortisone shot. I want to get back on the basketball court. The answer is no. Why? Because we don't want to interfere with the normal healing process, the normal inflammatory process that the body needs to go through. Okay. So cortisone's reserved for more chronic injuries. For someone that comes in and says, hey, it's been 4 or 5 months, I've been dealing with this deep heel pain. I've tried resting, I've tried ice, I've done some anti-inflammatories, I've reduced my activity for a while, nothing seems to help. That's when we start talking cortisone, to get in there and kind of break up that deep inflammation, break up that inflammatory response, that chronic tissue, and get things rolling to kind of get people moving and better quicker. So in people with plantar fasciitis, that's a tool that we often use. We use it for certain, ankle injections as well. Sometimes we use cortisone for scar tissue. Sometimes people have something called a neuroma, which is a swollen nerve here, and that tends to decrease some of that deep inflammation. People sometimes have fibromas, which are little nodules on the bottom of the arch that we can break up some of that fibrous or scar tissue down there. So that's kind of what cortisone is intended for in terms of the foot and ankle. And there's certain areas that we never really inject cortisone into. So people with Achilles tendonitis, definitely contraindicated, because we don't want to weaken or compromise the Achilles fibers, because that could lead to a problem or even a rupture.
Now, Doc, going back on the foot mode for a second, we were talking about, and you brought up about different fractures. You didn't say breaks. You used the terminology of fractures. Now, how, although you see it precisely as that, how do us walking around as lay people decide whether it's something that's not just a sprain, but we've entered into the realm of fracture of some sort?
Right. So basically, I always say, if you injure something and it's kind of out of proportion, you can't put pressure on it, it's really swollen, that's something you need to get evaluated and you need x-rays. Okay. If you have an injury and you can, kind of grin and bear it, and it's not that bad, and you can give it 2 or 3 days and then kind of make that decision whether it's something you need to have evaluated, then that's fine. But generally, the only way to really know if you have a fracture is to do an x-ray. And not all fractures are equal. There's some fractures that aren't that bad, and then there's fractures that are worse. And all fractures require different types of treatment. For example, if someone fractures a toe, it may not be a big deal and may just, kind of, decrease your activity, maybe wear a sandal or, fracture shoe for 2-3 weeks and then kind of resume as tolerated. But then other fractures are much more substantial. For example, a fracture at the head of the metatarsal bones that's not displaced is not that problematic and tend to heal well, whereas that same fracture at the base of these metatarsals, that's a much bigger problem. And the treatment requires more strict immobilization, oftentimes a hard cast, oftentimes crutches, oftentimes off your foot. Whereas a fracture here, you can bear weight on it a lot sooner. So it really depends on what the fracture is and where it is. Likewise, fractures that go into the joint have a much higher incidence of developing post-traumatic arthritis, which is joint stiffness and chronic joint pain. Fracture that doesn't invade or enter that joint is less likely to cause that kind of a problem. So it's really good to know where the fracture is and kind of what the long-term sequelae is of that fracture, so you kind of know what you're looking at in the future.
Okay, now I got a couple of toe questions for you, Doc. I'll start out with one. The most common one I've seen and heard about is a scenario, I don't know if it's the layman's term or the doctoral term, called bunions.
Yeah, probably one of the more common things I see in my practice. A bunion is basically a deviation of the big toe. Okay, so this bone right here, the first metatarsal, this is a normal foot anatomy. So obviously this doesn't show the bunion, but a bunion would be basically a divergence of this bone kind of going in that direction, and then the big toe basically kind of going in that direction. And what you're looking at is this prominence here on the first metatarsal head. So whenever I see someone with a bunion, we talk about kind of, how symptomatic that bunion is, because if you have a bunion and it's not painful, we usually don't really get into surgery. Whereas if that patient's having pain, then we start talking about options. When you're talking about bunions, you really have two options. One option is to essentially live with that bunion. And what that means is, yeah, you got a bunion, wear wide shoes, wear shoes that don't irritate or rub against the prominence here. Be mindful of the material on the shoe, meaning use shoes that have a material that expands, that doesn't constrict the bunion. Maybe even, sandals where this area of the bunion is open, so it doesn't develop any pressure. And then the other option, of course, is surgery. And not all bunions are equal. So you've got some bunions that are mild, some that are moderate, and then some that are severe. And the surgical procedure is different for all of those bunions. But generally, a bunion that's mild to moderate, we do a traditional bunionectomy procedure where we make an incision over the skin, right over the bunion prominence. We use a saw to shave some of the prominence down here, and then we make a cut in the bone here to shift that bone over to get that correction. Okay. Sometimes we have to do a secondary cut in the toe if the big toe is leaning towards the second toe to bring that straight. So it's essentially shaving the bone, fracturing the bone, shifting the bone over, and then using a screw or pin to fixate that bone and hold it in position long enough to allow that to heal. The recovery from something like that is, 2 weeks kind of off your foot for the most part. And then at 2 weeks, the stitches come out, and then kind of weight bearing is tolerated. But something like that oftentimes takes 2 to 3 months to fully heal, sometimes even longer until you're really back into activity in sports and shoes. And that's kind of a more traditional bunionectomy. And for the people that have more severe bunion, meaning when this bone's really kind of jetted out and the angle is larger between the first and the second bone here, the procedure needs to happen down here because we're able to get a larger fulcrum or ability to correct for that deformity or bunion. And again, when we get back to this part of the bone over here, the healing is slower. Patients oftentimes have to be in a splint or a hard cast for several weeks off their foot. They can't start early weight bearing. And it's a more delicate surgery, longer recovery. Okay, so smaller bunions, simple procedure; larger bunions, more complicated, slower healing.
Now, just quickly to touch on. Now, that's different from what people call hammer toes, right?
Correct.
Okay, so did hammer toe something that's developed or something that people born with, or?
Yeah, so most of the time it's genetic. Most of these things are genetic, meaning
Okay.
bunions, hammer toes. Basically, there's a couple of different scenarios. A hammer toe is a toe that's basically hammered, okay, right over here in this joint, okay, the proximal joint right here. A mallet toe is a toe that's hammered at the far joint here, and then a claw toe would be a toe that's contracted in both the front and the middle joint here. So when we see a patient with a hammer toe, we kind of evaluate where is the contracture deformity. Is it because remember, with the toe, there's 3 bones that make up the toe. So we want to identify where the contracture is, what joint. Obviously, just like bunions, option 1, you live with it, you're mindful of your shoes, you use shoes with a high soft toe box, or you consider surgery. Okay, and surgery for a hammer toe is easier than a bunion surgery. It basically requires a skin incision over the toe, resecting bone to get rid of that contracture, and then oftentimes pinning that toe to allow it to heal in a straight position. As you get to the lesser toes, a lot of times you don't have to pin it. And that's more or less what's required to address a hammer toe. Sometimes the contractures are a little bit more significant and you have to do bone work at the metatarsal level as well. That becomes a little bit longer recovery. Sometimes you have to rotate toes around because they're not only contracted, but they're rotated. So depending on what the deformity is and where it is, kind of determines what the procedure needs to be. But again, with hammer toes, it's essentially kind of live with it or consider surgery. There is one other thing that I do in my office, a nice little trick. It's called a Flexor Tenotomy. It's for people that have reducible hammer toes. So, if you have a hammer toe, you'll see that you can either straighten the hammer toe out or you can't. And if it's a rigid hammer toe, then it's definitely bone surgery. But if you have a flexible hammer toe that you can reduce, sometimes we do a little trick in the office where we basically just come in with a little needle and release the tendon on the bottom of the toe. It's called a flexor tenotomy. We snap that tendon just through a little needle hole. We use the bevel of a needle to, kind of like a windshield wiper technique until that tendon snaps or releases. And it basically gets rid of that contracture of the toe. It's a real easy procedure that can be done in the office. The recovery is just a few days, and that oftentimes corrects those flexible hammer toes. Obviously not for rigid hammer toes, but something to be considered for flexible toes.
Yeah. Now, I'd be remiss. I have Beverly from Culver City. She had a question about how often and how high, because she says that she likes to go out and she likes to show off her calves because she's worked hard for them. And she likes wearing the high heels, the very high heels and spiked heels. Now, is there a downside to that in the long run for health?
Yeah. So, what I tell my patients is everything in moderation, right? You can have your dessert as long as you're eating healthy for the most part, right? So that's kind of how I look at, shoes like that. Obviously not everyone can tolerate a high heel shoe, but for those women, girls that can, great. There'll probably be a time that they can't. So, might as well seize the moment. So use your judgment. Obviously, if your feet are hurting and you're using high heels, don't do it. Ironically, some of my patients, especially my patients with Achilles tendonitis, where they get that pain along the Achilles tendon or the calf, I recommend a high heel because what that does is it raises the heel and takes the stress or the tension off the Achilles tendon long enough to kind of let that heal. But you definitely don't want to be that person that says, hey, I can wear high heels, but I can't wear flats. And that's because you're so adapted and used to wearing the high heel that everything's kind of contracted. And now you can't get your foot flat. You don't want to be that person. So everything in moderation. If you do use high heels, make sure you stretch. Make sure you do use, tennis shoes or flats. But I'm sure everyone knows that person that says, hey, I can wear high heels and I'm comfortable, but I can't wear a flat. And that's because they're so used to wearing a high heel that everything's kind of contracted and tightened up.
Now that's a good one because, like I said, they talk about trying to enhance their calf muscles and whatever else. So I'm sure just trying to balance on some heels would do more than enough to kind of like tighten up the different muscles and you got to be very careful. So I appreciate you doing that, talking about that. And like you said, wearing sensible shoes at all times. There's something called sense and sensibility, and then there's something called leave it alone, it doesn't work. There's another question I have, but I think we're down to our last few minutes, and this may take longer than long. But is there really a good treatment for neuropathy, which is nerve damage, sometimes caused by diabetes and some of the other stuff?
Yeah, it's a good question. Tough problem. I'm sure there are people that'll tell you that there are treatments. I can tell you in my practice, it's probably one of the more challenging and harder things to deal with and treat. There's a lot of different causes of neuropathy. I would say the most common cause of neuropathy meaning loss of sensation. Okay. Neuropathy generally, is nerve damage, and people with neuropathy present with different types of presentations. Some people have tingling, numbness, burning of their feet, and then other people have, complete loss of sensation of their feet. So and some people, they don't necessarily have pain associated with neuropathy. It's more of just a generalized numbness, and then other people have excruciating, debilitating pain with neuropathy. When I see a person with neuropathy, I'll try to get a sense of where their neuropathy is coming from. Is it diabetic peripheral neuropathy? Is it originating from their back, like a nerve impingement, nerve compression type of neuropathy? Certain drugs, chemotherapy drugs, can cause drug-induced neuropathies. Certain vitamin deficiencies, like the B vitamins, can cause vitamin deficiency neuropathies. Certain traumas, prior surgeries, alcohol neuropathy, So there's lots of different types of neuropathy. So I try to identify where the cause of the neuropathy is. Once you can identify that, then you can try to initiate some kind of sense of treatment, whether it's physical therapy if it's coming from the back, or a sciatica. Obviously, if it's a diabetic neuropathy, we work on diabetic management. If it's a vitamin B deficiency, we get blood work that up, and supplement. So we do that. I haven't really found too many effective treatments on reversing neuropathy in patients that have severe neuropathy, but there are different classes of medications that we use for treating painful neuropathy. There's one drug called gabapentin. There's another drug called Lyrica. We generally start with kind of a low dose and start titrating up. Some of those drugs do cause tiredness, so you tend to take them more towards the end. But a lot of people with neuropathy tend to be more symptomatic towards nighttime or during the night anyway, so that works out okay for them. There's different clinical trials being done for neuropathy. There's different procedures for nerve releases, but a very, very challenging problem to deal with.
I appreciate it, Doc. Thanks a lot for answering all my questions and all of our emailers' questions, guys. Thank you for emailing these questions in. And once again, man, we appreciate the expertise. And this is what we do each and every time we bring you health from the inside out. We don't want you just to look in the mirror and just see what's on the outside, but we also want you to feel good and be able to maintain that outside from what's happening, enriching and maintaining the inside, because always remember that health starts from the inside out. See you next time. This is Dee Nice.